What investigations can we do to help confirm our presumed diagnosis? Well, blood tests would be a good place to start. In diverticulitis, as when we investigate any type of abdominal pain, we're going to do a full complement of blood tests. These include FBCs or CBC, renal function, liver function tests, amylase, and CRP. The main abnormalities we would expect to see in diverticulitis would be an elevated white cell count, or leukocytosis, and also a raised CRP. And these would go up in keeping with the presence of inflammation or infection. If our patient is significantly dehydrated as a result of infection or sepsis, we would expect to see some derangement in their renal function which reflects this. And this is principally in the form of a raised urea or a raised creatinine. With regards to amylase and the liver function tests, we wouldn't normally expect these to be significantly raised in diverticulitis. However, it's important that we check them to ensure that there's no pancreatic or biliary cause of our patient's symptoms. An additional blood test to be aware of, and one that's more commonly used in North America and some areas of Europe, rather than the UK, is ESR, or erythrocyte sedimentation rate. Similar to CRP, ESR also becomes elevated in the presence of infection or inflammation, and therefore we would expect it to become elevated in diverticulitis. However, because of the similarities to CRP, in terms of the information that it provides, we tend to either use one or the other, often dependent on the preference of your hospital or country of practice. As well as blood tests, we can also check the patient's urine. We do this to look for any evidence of infection, and also to look for any signs of hematuria, which, if present, may indicate the presence of a urinary tract stone. In women of childbearing age, we should also be checking to make sure they aren't pregnant, and also, really importantly, to make sure they don't have an ectopic pregnancy. In terms of imaging, we can do some X-rays, or we can do CTs. In most cases, X-rays aren't really that useful. However, if someone has a significant perforation as a result of their diverticulitis, they may have a pneumoperitoneum. And we should be able to identify this by looking for free air under their diaphragm on their erect chest X-ray. And we can see this nicely demonstrated in this image. Now looking at CTs. As well as showing simple diverticulitis, CT scans are also able to demonstrate some of the complications that may occur, such as abscesses or collections, and also free abdominal air or fluid that may occur with larger perforations. Now, some of you may be thinking, why don't we do a colonoscopy and have a look inside the colon? Well, this is actually something we definitely want to avoid doing, particularly in the acute phase of diverticulitis. As during a colonoscopy, the endoscopist has to distend the colon with air so they can get a better view. Now, obviously, if the patient has a perforated diverticulum, which has somehow managed to seal itself off, the last thing we want to do is inflate that colon. As by inflating the colon, all we do is increase the pressure within the lumen. And as a result, we increase the risk of opening up that perforation again and potentially making the patient much worse. So in a nutshell, in the acute phase of diverticulitis, colonoscopy is a big no-no.